some of the current applications for 3D imaging. We have our implant imaging and treatment planning, developmental abnormalities, third molar and canal relationships, periapical and periodontal findings, trauma, pathological findings. You can see sinuses and nasal fossa, orthodontic applications. Then there's segmentations, 3D printing, AI, and other 3D. So there's just a huge amount you can do with your scans. Now, by far the driving force was implant treatment planning. So when we're looking at our scans, just a generalized rule of thumb, 2D consistently underestimates the bone loss, and it consistently overestimates the bone gain. And we see that time and time again. What can we use our 3D for? Well, it really helps us in understanding the true availability of bone height. Our ideal image should provide us with cross-sectional images, maybe the inclination of our alveolar process, all of the location of anatomical structures, allow for evaluation of density in some regard, although with our CBCTs, we actually don't have true density. So we have not really moved beyond our visual inspection. And that's because we don't have that super highly collimated fan beam that they have in medicine. And we have lots of noise in our images. But it allows the clinician to be able to identify the area clinically and whether it's accessible at a reasonable cost to that patient. So many of the software will allow us to try out various implants, the length, the diameter, figure out our axis of orientation, exactly how we want to place that, the ideal anatomical location for implant treatment planning. And 3D imaging has, as I said, it's really brought in because of the desire to better visualize all of that anatomy for our implant placement. Now, so this one is a 2D pan, and based on the 2D pan, you can see that our implant that's been positioned there looks pretty good. It looks restorable. And where is that actually? Well, the 3D actually tells the truth. And so we can see that our 2D kind of lied to us. It didn't really tell us exactly where that implant was positioned. In fact, if we look at it in our cross sections, you can see there's very minimal bone that's actually holding that implant in place. Here's a great example. This is using our cone beam CT data, our CEREC, and this is using the CCAT implant planning software, but you can virtually plan that implant for that patient. And you've got a huge catalog to choose from, different sizes, widths, or lengths and widths, different systems. Whatever it is that's your favorite will probably be in there. You can go ahead and pick that, and you can just try it in and figure out your axis of orientation, where you'd like to put that in relationship to any of the pertinent anatomy, and come up with your entire treatment plan. And then once you have figured out exactly what you want to do, then you can send that off within the software to order a surgical guide. So this is a great example of how easy this has become. And well, I'll have to tell you, I wish I knew this early on, because I was always so afraid of placing implants when I did general dentistry. And of course, this technology has just made it so incredibly simple.